Hi, my name is Anne McInnes, and for Unit 4, I decided to do Case Study 2 and Case Study 3. So for Case Study 2, a 4-day-old infant, otherwise known as Patient A, presents at the clinic. Her birth weight was 5.9 pounds. Her mother had a normal pregnancy and delivered the patient vaginally. The patient's newborn screen showed an abnormal result for phenylalanine, with the patient's level being 6.6 in the reference range between 1 and 2. A presumptive diagnosis of phenylketonuria was made and additional samples were obtained. The patient's denied any family history PKU. If diagnosed with PKU, it would be indicated that the patient has a defect in the enzyme phenylalanine hydroxylase, which is responsible for the conversion of phenylalanine to tyrosine. Due to the deficiency in this enzyme, the normally non-essential amino acid tyrosine will become an essential amino acid. The supplementation of tyrosine is crucial as tyrosine is a precursor for thyroid hormones as well as melanin. But the supplementation does not cure PKU as it does not fix the abnormal level of phenylalanine. As a result, the doctor puts the patient on a PHE dietary restriction diet. After initiating this diet, the patient's plasma phenylalanine levels were 1.65. The patient's levels decreased and became within normal limits as a result of the low PHE diet. The restriction of phenylalanine in one's diet with PKU is crucial as it is the only way to keep levels down as the enzyme that normally would reduce this level, phenylalanine hydroxylase, is defective. Another infant, otherwise known as Patient B, is being evaluated for suspected PKU. Both infants underwent a BH4 loading test. Patient A had a rise in PHE levels after the test, whereas Patient B had a dramatic decline in PHE levels. This differing result indicates that Patient B does not have the same enzymatic defect as Patient A. The test shows that supplementation of BH4 has no effect on Patient A, which would be expected as we have found that Patient A's defect is in the enzyme phenylalanine hydroxylase. This is different from Patient B, whose PHE level dramatically decreased after supplementation of BH4. This indicates that Patient B has a defect in bioprinterin metabolism, which is often caused by a mutation in BH4. Patient B does not have a defect in phenylalanine hydroxylase, but has a defect in BH4, which is a cofactor for phenylalanine hydroxylase. For Case 3, a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight and reports that the pain started last night and has increased in severity. Following his physical exam and laboratory findings, he is diagnosed with gout. The patient's plasma urate level was 10.5, with the reference range being less than 7. And his urinary uric acid level was 215, with the reference range 413 plus or minus 78. The clinical presentation of gout is a result of hyperuricemia, which can be caused by overproduction of uric acid or underexcretion. In some cases, the patient suffers from both overproduction and underexcretion. It can be concluded that the patient's presentation of gout is due to the decrease in urinary excretion of uric acid. The conclusion can be made by looking at his urinary uric acid level, which was significantly lower than the normal level. And although we cannot rule out that he's affected by not only underexcretion but also overproduction of uric acid, which can be caused by overproduction of purines, which may be a result of dietary habits, or could be caused by a decrease in the salvage of purines, which would cause an increase in bases, thus an increase in urate. Based off his lab result, it is only confirmed that he is affected by underexcretion. To understand the root cause more in depth, it would be beneficial for the provider to obtain a more in-depth health history, including current prescriptions, the patient's BMI, as well as any other current diagnosis, as these can influence hyperuricemia. After further discussion with the patient, he states that he switched from diet soda to regular soda due to his concern for fake sugar being bad for him. The patient drinks approximately 4 to 5 liters of soda per day. This dietary change can contribute to his hyperuricemia and thus worsen his gout. The metabolism of fructose, which is the sugar in regular soda, causes a decrease in intracellular phosphate, which stimulates AMP deaminase. The AMP deaminase catalyzes the conversion of AMP to iosine monophosphate, which increases the rate of purine degradation and thus increases the production of uric acid. Therefore, this dietary change will worsen his gout as it will increase his uric acid levels.